Okay. Hello, everyone. Welcome to the glaucoma lecture series number 5. Today's topic is going to be on secondary open angle glaucoma. This is a continuation of the previous lecture that we gave last week. My name is Ramesh Ayala from Tulane School of Medicine, New Orleans, Louisiana. This program is brought to you by MediTred, a leader in online training and education. So the topics that we're going to cover today include tumors, inflammatory glaucoma, elevated episcleral venous pressure, trauma related to glaucoma, penetrating keratoplasty and glaucoma, retinal diseases and glaucoma, drugs and glaucoma, and lens-induced glaucoma. The common factor in all of these disease process that we're going to discuss today is elevated intraocular pressure with an open angle. If I may take my pointer and draw, let's see, a marker. Good. Let me see if I can draw this for you. Here is the angle anatomy. I'm trying to draw the cornea here, and here is the iris with the ciliary body right here. So this is the angle structure that we're talking about, right? So if I enlarge this and draw a nice big picture of this, it will be something like this. You will have the trabecular meshwork with linear beams taking the aqueous across. This, of course, is a cut section. And you have your Schlem's canal located here. So when we talk about open angle glaucoma, we are saying that this angle is open. However, because it's glaucoma, aqueous is not reaching its target site, which is the Schlem's canal and beyond. And let me draw the collected channels here. Okay. So in primary open angle glaucoma, there's an obstruction somewhere in this location, what we call as the juxtacanaliculated area, JXT. Okay. And this is the TM, the trabecular meshwork. And here is the Schlem's canal. Okay, now that's clear. So in primary open angle glaucoma, the resistance to the aqueous outflow is located in the juxtacanalicular portion. Whereas in a lot of disease processes that we're going to discuss today, the obstruction is somewhere in this area, in the trabecular meshwork itself. For example, if you have tumors causing glaucoma, the tumor cells are probably blocking the trabecular meshwork pathway by occupying the space here. And that's the reason why aqueous is unable to go through. Same thing with hemolytic glaucoma. Blood in the chamber, following trauma, for whatever reason, those cells are going into the trabecular meshwork and they block the trabecular meshwork pathway here, so aqueous cannot access the canal. Now, there are some glaucomas, such as the drug-induced glaucoma, the steroid-induced glaucoma, that does increase the resistance in the juxtacanalicular area again because of continuous deposits of glycosaminoglycans in this area, increasing the resistance, causing the pressure to go up. And occasionally there could be a problem at the level of the Schlem's canal or beyond that can also present as a secondary open angle glaucoma. Classic example being elevated episcleral venous pressure. And we'll discuss the conditions that lead to this condition. So I want you to look at this drawing, understand the concept. Primary open-angle glaucoma, secondary open-angle glaucoma. In primary, we know that there is a resistance at the level of the juxtacanalicular area, and it's usually a familial/genetic disorder. Whereas in secondary open-angle glaucoma, the angle is still open. However, there is a secondary pathophysiology mechanism that's taking place, blocking the aqueous pathway from accessing the Schlemm's canal, causing the pressure to go up. Now let's go on to discuss individual topics, tumors and glaucoma. So the basic mechanism, like I just described, is direct invasion of the trabecular meshwork area, either by the ciliary body tumors or iris melanoma cells. The angle can also be closed in some of these cases by ciliary body rotation, pupillary block mechanism, or neovascular glaucoma. This is typically seen in patients with retinal and choroidal tumors. Sometimes the necrotic tumor cells and macrophages can block the trabecular meshwork, causing glaucoma. Most common adult cancer causing glaucoma include uveal melanomas, metastasis, leukemia, and lymphoma. Whereas in children, it is retinoblastoma, juvenile xanthogranuloma, and medulloepithelioma. Most cases with direct invasion result in enucleation. By the time these patients come with glaucoma secondary to this cancer, there's not much that you can do to resolve this cancer in terms of treatment, and a lot of these eyes end up in the bucket, i.e. status post-enucleation, because the eye becomes extremely painful and has spread so widely at this stage that even if the patient still has useful vision, the recommended treatment at that point would be to enucleate the eye. The better treatment modalities that are coming up, and I would encourage readers to look up Dr. Jerry Shield and Carol Shield's literature to update yourself on this aspect of glaucoma. Here is an example of a patient that was referred to me several years ago with the iris tumor, and ultrasound picture of the same showing the nevus at this stage not increasing in size, but you can potentially think through this process, if this nevus, there's a 5% risk that this nevus can potentially increase in size and cause a melanoma. And this melanoma left untreated can deposit cells in the trabecular meshwork area and angle, or can directly spread into the angle structures, causing the pressure to go up. So most iris tumors are benign nevi, and like I just mentioned, there is a 4% chance that this nevi can convert into melanoma cancer in 10 years. Remember A, B, C, D, E, F in terms of classifying these tumors as to when they are likely to turn into cancer. A for age, if you're less than 40 years of age, blood or hyphema in the anterior chamber, the clock hours of mass, especially those that are located inferiorly, diffuse configuration, ectropia on UVA, and feathery margins. So the tumors that are associated with the blood are located inferiorly with the diffuse configuration associated with ectropia on UVA and feathery margins are likely to convert themselves into cancerous melanomas, and they need to be aggressively treated. Localized melanoma, obviously the treatment is a local excision, but if the metastasis is but if it has already spread into the angle and has caused glaucoma and the angle is involved 360 degrees at that stage, you may potentially have to consider enucleation, as we discussed in the previous section. Metastasis to the iris is extremely rare, just as a point for you to remember for your OCAPs. Let's move on to the second category for discussion today, uveitis and secondary open-angle glaucoma. This is a fairly big topic, and I'll try and highlight those aspects that are relevant for board review purposes and also for you to gain a basic understanding. The mechanism of uveitis causing glaucoma is multiple. Trabeculitis, which is inflammation of the trabecular meshwork itself, can lead to edema and cell dysfunction, causing glaucoma. WBCs, white cells and proteins, blocking the trabecular meshwork. Remember, when you have uveitis, the blood aqueous barrier is broken, and so white cells and proteinous material can leak into the aqueous humor, and via the aqueous humor can travel into the trabecular meshwork, block the TM, cause the pressure to go up. Chronic inflammation can give rise to peripheral anterior synovial formation and angle closure, giving rise to elevated intraocular pressure. The treatment for uveitis, often the first line of treatment is steroids, and if the patient happens to be a steroid responder, this in itself can cause the pressure to go up. And so you have to discern whether the elevated intraocular pressure is steroid induced from the treatment or as a result of uveitis itself. Pupillary block from synovial attachments between the pupil and the lens capsule, and should this happen, you will notice that these patients will develop iris Bombay. Let me see if I can demonstrate that to you. Here is the cornea again, and if this is the normal iris, and here is the lens, underlying lens. If there is an attachment between the pupillary margin and the underlying lens capsule, obviously aqueous is going to accumulate in this area and cause the iris to balloon up forwards. And you will see iris Bombay being formed like this. And this will cause obstruction to the angle structures here and cause the pressure to go up. Treatment for this obviously is pretty simple, is to create a PI, make a hole through the iris here, and multiple PIs usually are indicated for this to unblock or to create an alternative pathway for the aqueous to come forwards into the anterior chamber, and that will cure this problem temporarily. Obviously, you got to take care of the uveitis too, but you can see that the multiple mechanisms by which a patient with uveitis can develop secondary glaucoma. So the treatment of a patient with uveitis and glaucoma consists of the following. Steroids obviously are the mainstay to control the inflammation, but also remember steroids can in itself cause glaucoma, something to keep in mind as you treat this patient population. There are a couple of drugs that you should avoid, including myotics, as they may worsen the inflammation. Myotics, like such as pilocarpine, can break the blood aqueous barrier and as such can make the aqueous more proteinaceous and cause the pressure to go up. So you want to avoid myotics. Prostaglandin analogs may worsen inflammation, especially in patients with hepatic keratitis. And so something that you should be aware of and should avoid. So you can use aqueous suppressants such as beta blockers in these patients, carbonic and anhydrase inhibitors, adrenergic agents, alpha agonists. Those are all safe medications for you to use to control the intraocular pressure in this patient population. Try to avoid myotics and prostaglandin analogs unless it's an emergency. Remember, laser iridoplasty is contraindicated in the sense that it does not work and it can actually make the situation worse in the presence of active uveitis, and so it should not be attempted. Peripheral iridectomy or iridotomy using the YAG laser is indicated should you have iris Bombay, as we discussed in the previous slide. If and should the glaucoma becomes uncontrollable and the pressures continue to be high in spite of your treatment, then these patients should be subjected to some kind of surgical intervention. Trabeculectomy with mitomycin C, glaucoma drainage device surgery such as an Hammett valve are all indicated in this kind of setup. And we'll discuss this briefly towards the end of it. But briefly, remember, just the plain trabeculectomy operation is unlikely to be successful in the absence of mitomycin itself. adjunctive use of mitomycin C. My preferred choice in this kind of cases is to use a pediatric Amit valve and mixed with intravitreal Kenalog injection. The intravitreal Kenalog injection controls the inflammation, whereas the pediatric Amit valve will control the pressure. And combination of the two has given me excellent results in the long term. That in itself is a different talk, and we'll cover this topic during our glaucoma drainage device surgery. But remember, that these eyes are kind of tricky. If you use a large plate glaucoma drainage device as a mode of treatment in these patients, the patients can develop hypotony in the long term, something to be aware of. So the other treatment modalities that are out there from the uveitis control point of view that you should be aware of, at least in theory, especially from your board's point of view, or the immune suppressive therapy. These include the antimetabolites such as methotrexate, T-cell calcineurin inhibitors such as cyclosporine and tacrolimus, alkylating agents such as cyclophosphamide. Now, these alkylating agents have the most side effects and hence are least commonly used in uveitis world. My preferred drug is methotrexate. It's given me good luck with a lot of my patient population with uveitis. There are also biologic agents that are being used in the present day, such as infliximab, which is a TNF alpha antagonist. It's especially useful in uncontrolled uveitis in patients with underlying sarcoidosis, Behçet's syndrome, pars planitis, Crohn's disease, juvenile idiopathic arthritis, and HLA-B27 uveitis. However, it has some significant side effects, including congestive heart failure, pulmonary embolism, vitreous hemorrhage, and unmasking of underlying tuberculosis and demyelinating diseases. We don't that much use, I mean, the IL-1 and IL-2 receptor antagonists are much less commonly used drugs, but they may ask you questions regarding these drugs. So at least you should be familiar with these drugs and the mechanism of action of these drugs, if nothing else. There are several kinds of specific presentations of certain kinds of uveitis that you should be aware of. Glaucomatous-cyclitic crisis, which is frequently asked but rarely seen in clinical practice. This is a condition that is often seen in middle-aged female patients. They present with unilateral blurred vision of a few days etiology with mild conjunctival injection, often mistaken for conjunctivitis. When you examine these patients, you will have a mild corneal edema with a few keratic precipitates in the lower half of the cornea. The patient can exhibit some mild eye pain. Intraocular pressure is usually in the range of 30 to 50 millimeters of mercury and is thought to be secondary to trabeculitis. Recurrent episodes may lead to secondary permanent open-angle glaucoma, which in turn needs permanent treatment, such as either in terms of medications or surgical intervention. Even though this is said to be unilateral, rarely it can become bilateral, and I have several patients in my practice who had bilateral glaucomatous-cyclitic crisis. And then the next condition that you need to be aware of, again, rarely seen but frequently asked in your boards, is the Fuchs heterochromic iridocyclitis, which is associated with heterochromia, i.e. discoloration of the iris compared to the other eye, low-grade iritis with stellate KPs, PSC cataract, secondary open-angle glaucoma. This glaucoma is usually seen in the hypochromic eye or the eye with less coloration. It's typically seen in middle-aged people. And one other aspect of Fuchs heterochromic iridocyclitis is the presence of these fine vessels on gonioscopy. These are not new vessels. You got to distinguish this from new vessels. These fine vessels that you see on gonial, they tend to bleed when you open the anterior chamber. They can bleed spontaneously sometimes, or more likely when you're attempting to do cataract surgery in these patients and you make the entry into the anterior chamber, you can see these blood vessels can start bleeding. Note that steroids are not effective in controlling this low-grade inflammation, even though we all use low-dose steroids on a continuous basis to suppress the inflammation. The glaucoma, when it becomes uncontrollable with medications, we need a mitomycin C trabeculectomy. Cataract surgery is pretty straightforward, except that the patient may have some PSA synovial adhesions, and so will require some complexity in removing it. Let's move on to juvenile idiopathic arthritis. Again, a rare disease that you probably will not see in your clinical practice, however, frequently asked in the exam. The ocular complications of JIA include 20% incidence of glaucoma, 16% incidence of band keratopathy, 20% incidence of cataract. So just remember 20% of glaucoma, band keratopathy, and cataract. So all the three anterior segment disease processes are seen in this disease process. There are several questions that are phrased out for you, so you can remember JIA in relation to glaucoma much better from your exam point of view. Uveitis in juvenile idiopathic arthritis is associated with HLA-B27. True or false? The answer is false. This B27 is associated with more severe joint involvement and spondylitis in male patients with JIA, but not necessarily the development of uveitis. Uveitis is most likely to occur in the following patient. Which is the correct answer, A, B, C, or D? Obviously, the correct answer is D. Pauciarticular, ANA positive, rheumatoid factor negative, especially lower joint involvement with sparing of the breast is associated with this condition from ophthalmic point of view. What is the difference between, let's move on to the lens-induced glaucoma. Now, there is a separate lecture that's been done by my good friend, Dr. Sandra Johnson, that's already up on the website. I would request you to review that for details of the phacolytic glaucoma. But in the I just wanted to review phacolytic briefly, lens-induced glaucoma to complete this lecture here that we have at hand. So what is the difference between phacolytic and lens particle glaucoma? You'll see that the escape of lens protein from mature and hypermature cataract causes the phacolytic glaucoma. So in this case, you have a hypermature cataract and the capsule is still intact. However, the protein is leaking out through the capsule, getting deposited in the trabecular meshwork, causing obstruction to the outflow pathway. Whereas in lens protein in the lens protein glaucoma, the cortical material is following cataract extraction, capsulotomy, or ocular trauma. So there is more inflammation in phacolytic glaucoma than the lens protein glaucoma. Let me see if I can explain this to you a little bit better. I'm drawing two situations. One will be the phacolytic, the other one will be the lens particle. Okay, so here is the phacolytic glaucoma where the capsule is intact, but the the cataract is hypermature, and this lens protein is able to leak into the anterior chamber and getting into the trabecular meshwork and blocking it. In these cases, you should be able to see the lens particles deposited in the pupillary margin. Sometimes you can see it on the corneal endothelium, and clearly on gonioscopy, you will see these white particles, fluffy material in the trabecular meshwork. It's not at all difficult to make a diagnosis. In fact, the classic papers on this were written by Dr. Dave Epstein in his 1970s. I think it's published in 1970s, sometime in 1970s or 1980s. Please look it up. Those are some classic papers described from Massa, India, a long time ago. Whereas in the lens particle glaucoma, you will see that there is an opening in the capsule that's already made, and this opening could be following cataract extraction, could be from trauma. Whatever the situation is, the capsule is already open, and the retained cortical material that's there and is trying to escape out through this open capsule into the anterior chamber and then consequently into the trabecular meshwork, causing the obstruction to the trabecular meshwork, outflow pathway, and glaucoma to happen. In neither of these cases will you see KPs, but like I mentioned, you can see the fluffy lens material scattered in the anterior chamber. Obviously, the treatment for both the situations is to take that cataract out. So the lens particle glaucoma can happen weeks to years after the surgery or trauma, whereas in the phacolytic glaucoma, you will always see the cataract. If the cortical material that is there is limited, the lens particle glaucoma may sometimes resolve with medical treatment, i.e. steroid drops along with glaucoma medications, whereas phacolytic glaucoma is always treated surgically. For the major part, you can argue that in both the situations, the treatment is surgical most of the times, whereas it's always in the phacolytic glaucoma and most times in the lens particle glaucoma. Again, give examples of lens-induced closed-angle glaucoma. These include phacomorphic glaucoma and ectopia lentis. Again, I would suggest for everyone to review the excellent talk given by Dr. Sandra Johnson. It's available on our website on this topic. The most common cause of glaucoma following primary or metastatic tumor of the ciliary body is a direct invasion of the angle structures. Two drugs to be avoided in the presence of ocular inflammation: pilocarpine and prostaglandin analogs. Okay, let's go through the next condition that can cause the pressure to go increase in the presence of open angle: elevated episclerovenous pressure. Normal EVP, as we discussed in our pathophysiology lecture, is between 8 and 10 millimeters of mercury. Elevated EVP can result from AV malformation. We had a long discussion about this, I believe, in the pathophysiology lecture, but let me review this briefly. So AV malformation, such as a dural and the CC fistula in the carotid cavernous sinus, orbital varix, Strudge-Weber syndrome, venous obstructions such as in retrobulbar tumor and thyroid-associated orbitopathy, superior vena cava syndrome, and sometimes idiopathic. All these situations can give rise to elevated episclerovenous pressure, and these patients present with elevated intraocular pressure, dilated episcleral blood vessels that stand out against a white background. This is pretty classic, and a lot of these patients sometimes are mistaken as pink eye patients and treated as such before the actual diagnosis is made. If you do gonioscopy in these patients, you will see blood in the Schlemm's canal, and especially if this situation happens acutely, the patient will, such as in acute CC fistula following trauma, the patient may have proptosis and may also complain of buzzing sound in the head. In fact, I recently had a patient who woke up suddenly in the middle of the night with a buzzing sound on her right side, and that did not go away. Further investigation revealed that she somehow spontaneously developed a CC fistula that resulted in resulted in that buzzing sound because of blood flow across his fistula, and also she developed acute proptosis and elevated intraocular pressures. Treatment in these cases from the glaucoma point of view, aqueous suppressants are most effective. ALT, again, is not effective in this situation. Filtration surgery may be complicated by ciliocoroidal effusions or suprachoroidal hemorrhage, so you got to be careful. The particular patient that I talked about, I did a glaucoma drainage device implantation for her, and she has done well in terms of control for intraocular pressure. Trauma is another big thing that can cause glaucoma, and you definitely, almost every single ophthalmology resident or practicing ophthalmologist would have encountered this by now, trauma leading to glaucoma. So once you have sustained trauma to the eye, they could be bleeding, and should there be a hyphema, you got to watch these eyes carefully, depending upon the degree of hyphema. If the patient presents at the time of presentation, the intraocular pressure is normal, you still will have to treat the inflammation that is associated with it and watch this patient and suggest bed rest to prevent a recurrent bleeding, which is more likely to happen between 3 and 7 days, and it's seen in approximately 5 to 10% of patients. So the recurrent bleeding is more likely to cause acute pressure spikes than the actual initial presentation. The acute intraocular pressure spike is the result of RBC, WBC, fibrin, and getting deposited in the trabecular meshwork and or direct injury to the trabecular meshwork itself. Now, the most the patients that you need to be really, really careful about following trauma are those with the sickle cell disease. So make sure that you ask for the sickle cell status of these patients, and if they have a particular propensity to have sickle cell, for example, in the US, anybody who's of African American descent, if anybody who's from the Mediterranean ancestry, we ask for sickle cell, and we do screen them for sickle cell if the patient himself or herself does not know the sickle cell trait. So beware of the sickle cell patient. The reason being the IOP spikes and the optic nerve damage are more likely to happen in this patient population following traumatic hyphema. And the reason for that is the stagnant acidic aqueous leads to RBCs to sickle, which have greater difficulty to escape out of the trabecular meshwork, leading to pressure spike. So if you do have a patient with sickle cell and the patient has a hyphema, you got to control the intraocular pressure aggressively, and should have a short fuse to take the patient back to the operating room to drain the blood out of the eye if you were not able to control the intraocular pressure with medications. Now, in terms of treatment to control the intraocular pressure following trauma, you can look at the 3 modes of treatment: topical medications, oral anti-glaucoma medications such as Diamox, and surgery. So there are some drugs that you would like to avoid in traumatic hyphema. For example, Diamox. You want to avoid Diamox in patients with sickle cell disease and renal failure. The reason for avoiding Diamox in patients with sickle cell disease, obviously, is because the Diamox can increase acidosis and cause a dehydration to some degree, both of which can lead to increased sickling of the RBCs that can worsen the situation, and in fact can precipitate a sickle cell crisis in this patient population. Adrenergic agonists with significant alpha-1 activity such as apraclonidine, epinephrine, should be avoided in sickle cell patients because of concerns regarding anterior segment vasoconstriction. Parasympatomatic agents should be avoided in all patients in hyphema, as it tends to move the iris, can stretch the iris, cause more bleeding and worsening of the inflammation. Let me go back one step, and to complete the the topic here. In terms of actual treatment and management of these patients, I tend to put these patients on a observation, daily observation, wherein we check the intraocular pressure, start the patient on some anti-glaucoma medication, such as an aqueous suppressant if the pressure is elevated more than 21 millimeters of mercury. Two, you want to start this patient on steroid drops. I typically use Pred Forte 4 times a day. Should there be epithelial disturbance, you may want to add an antibiotic drop along with it, and suggest to the patient to have bed rest, no physical exertion, to avoid recurrent bleeding, and monitor this patient. Should the patient present to you with, say, acute glaucoma with 100% hyphema, and the pressures are greater than 70 millimeters of mercury, you don't want to wait around for these patients to develop problems, as these patients are in severe agony at this stage. I typically take those kind of patients, this extreme end of these patients, to the operating room, and instead of disturbing the entire blood clot in the anterior chamber that can potentially cause rebleeding, I tend to put a Hammett valve into the anterior chamber and fill the chamber or the rest of the chamber with viscoelastic and Decatron, and control the pressure that way, and at the same time give a chance for this eye to heal and respond nicely, so I can come back and fix the rest of the problems that these patients may have. That is a topic in itself that we will not go into at this time, but sufficient to know that glaucoma should be taken care of actively in this patient population. Chemical injuries, again, we will deal only that limited section of this in relation to glaucoma. Chemical injuries leading to glaucoma are more likely to happen with alkali burns compared to acid burns. Now, following an alkali burn, the pressure goes up in an acute fashion, so within 10 to 20 minutes after the injury, to approximately 50 millimeters of mercury, from outer collagen coats shrinkage, meaning that the scleral collagen shrinks around the area of the trabecular meshwork, leading to the TM distortion. That's what causes the pressure to go up soon after the alkali burn. And then usually the pressure comes down, and in about 2 to 5 hours, the pressure can go up again. And this is from prostaglandin release into the anterior chamber in response to the chemical injury. Now, the long-term intraocular pressure increase in these patients is from PS formation or peripheral anterior adhesions between the iris and the angle structures. And in some of these patients, unfortunately, if the alkali gets its hands on the ciliary body and ciliary processes, it can give rise to permanent damage to the ciliary body, giving rise to permanent hypotony. And unfortunately, this could be the very end of these eyes, and a lot of these eyes end up as tricycle eyes by the time hypotony sets in. But the treatment at this stage, in the initial phases when the pressure is elevated, would include aqueous suppressants along with the use of steroids and other and vitamin C that we typically use for these alkaline acid burns. Apart from the fact that you got to take away the insulting agent completely from the vicinity of the eye as much as possible. And should the pressure continue to be a big problem, then you can, depending upon the amount of conjunctiva that is available, you may want to choose a valve, an Hammett valve to control the intraocular pressure. In these situations, which I've done in the past, a lot of these eyes, because of corneal melt, may end up having a keratoprosthesis, which again can cause the pressure to increase. And again, the glaucoma drainage devices is the way to go in this kind of cases to control the long-term intraocular pressure. The other aspect of trauma is angle recession, glaucoma, wherein there is a split in the ciliary body itself between the longitudinal and the circular muscle fibers. This is a frequently asked question. So in angle recession glaucoma, the actual damage is split between the longitudinal and the circular muscle fibers of the ciliary body. There's a 10% risk in 10 years for these patients to develop glaucoma. The fellow eye is at 30 to 50% higher risk of developing open angle glaucoma. And so some authorities believe that those patients who develop glaucoma following trauma or have an increased susceptibility to develop glaucoma in the long term anyway. These angle recession glaucomas can present to you as unilateral open angle glaucoma, one of the many causes that we will discuss in a later topic that can present as unilateral glaucomas. It can be distinguished from primary open angle glaucoma by the simple act of doing a gonioscopic examination, which will reveal the following findings: brown colored broad angle recess, absent or torn angle processes, white glistening scleral spur, depression in the overlying trabecular meshwork, in peripheral adhesions at the border of recession. Here is an example of what we're talking about. You can see in this gonio picture, this particular patient has a broad band of angle recess that is visible. The scleral spur, the white scleral spur is visible right about there. And then the rest of the slate color area that you see here is sometimes exposed portion of the ciliary body itself. And here is histopathology of the same, where you can see there's a split in the face of the ciliary body itself, separating out between the longitudinal and the circular muscle fibers of the ciliary body. This is an OCAP question that they frequently ask you in your boards. So how do you manage patients with angle recession glaucoma? Usual, you start off with the glaucoma medications or drops, aqueous suppressants, prostaglandin analogs, alpha-2 adrenergic agents. They all work in this situation. Myotics may have a paradoxical elevation of the intraocular pressure, something for you to remember. ALT, again, in this situation does not work very well, and so it should be avoided. Trabeculectomy versus express shunt with the help of mitomycin C has good success rate in this patient population, and can be tried when the glaucoma medications themselves don't work. Let's move on to cyclodialysis cleft, as is being demonstrated in this particular gonio picture. You can see the white sclera because of the disinsertion of the ciliary body longitudinal muscle fibers from the scleral spur. So the difference between cyclodialysis cleft and angle recession: cyclodialysis cleft, there is a disinsertion of the longitudinal muscle fibers from the scleral spur itself, giving rise to an alternative pathway for the fluid to access the supraciliary space, as opposed to angle recession, where there is a split in the face of the ciliary body between the longitudinal and the circular muscle fibers. So once you have here is a history of the same. Once you have once you have a cyclodialysis cleft, initially, because of the increased aqueous outflow pathway to access the supraciliary space, these patients initially have initially exhibit low pressures. But if and when the cleft is closed, either spontaneously or surgically, these patients can develop high IOP because of the memory or the lack of memory of the trabecular meshwork that's exhibited in the immediate aftermath of the cleft closure. A strange phenomenon, but is well described, and you should be aware of it. Let's move on to several surgical situations where the glaucoma can become a problem. If you leave behind a lot of viscoelastic following your cataract surgery, certainly the pressure will go up. This is more likely to happen when you use a dispersive viscoelastic such as sodium hyaluronate, especially the higher molecular weight forms such as the Helon GV or Helon 5. compared to the retentive viscoelastic agents such as the chondroitin sulfate. So remember, this is a favorite OCAP question. It's more likely to happen, IOP spikes are more likely to happen with the dispersive viscoelastic compared to the retentive viscoelastic agent. And if you do have a situation where the viscoelastic is retained at the end of the glaucoma, the cataract surgery, and the pressures are high, you can burp the viscoelastic out of the paracentesis site, put the patient glaucoma medications, and try putting in pilocarpine, which will stretch the trabecular meshwork open, so the high molecular weight forms of these viscoelastic agents can escape through the stretched out trabecular meshwork. In the worst case situation, you may have to go take the patient back to the operating room and wash out the viscoelastic completely. ALT and SLT, when you do this, the laser trabeculoplasties, especially in the presence of pigmentation such as pigmentary glaucoma, too much energy can give rise to post-laser IOP spikes. So it's something that you have to be aware of. And you can avoid that with the use of, you can avoid this IOP spikes with the use of alpha agonist prior to the laser procedure. It's not only alpha agonist, in fact, you can use a beta blocker, you can use a carbonic anhydrase inhibitor, any of these medications half an hour prior to the laser procedure, and then go ahead and proceed with the laser. And always make sure that you check the intraocular pressure about an hour after the laser procedure to make sure that you catch these IOP spikes and, if necessary, treat it appropriately. Following cataract surgery, PKP, penetrating keratoplasty, or filtering procedure, sometimes you can have IOP spikes. We just discussed that following cataract extraction. And if and should the pressure spike, you should take care of this glaucoma appropriately, depending upon how high the pressure is and what the status of the underlying optic nerve is. Let's move on to intraocular lens-related glaucomas. There are two that come to our mind. One is the UG syndrome or the uveitis glaucoma hyphema syndrome. Typically results from malpositioned intraocular lens causing chronic inflammation, chronic recurrent hyphema and glaucoma. So this IOL is rubbing against either rubbing against the underlying iris or the ciliary processes and causing this problem. And the treatment, of course, is to reposition the intraocular lens. Sometimes you can have secondary pigmentary glaucoma from a sulcus IOL or iris fixated IOL or a phakic IOL. Any of these situations can cause the shaping motion of the haptic portion of the lens, intraocular lens, against that iris, releasing the pigment in the anterior chamber, causing pigmentary glaucoma. Again, treatment is to tackle that lens which is causing the problem. Vitreous hemorrhage can sometimes present as glaucoma, hemolytic glaucoma, or ghost cell glaucoma, depending upon the stage of the vitreous hemorrhage. Hemolytic glaucoma is where the hemoglobin-laden macrophages escape into the anterior chamber and block the trabecular meshwork and cause the glaucoma to happen. Typically seen in patients where there is vitreous hemorrhage, say following trauma, in an aphakic eye or a pseudophakic eye where there's communication between the anterior chamber and the posterior chamber. Ghost cell glaucoma, on the other hand, is a delayed phenomena where in the RBCs, the vitreous hemorrhage is old. The RBCs have lost their hemoglobin, and these cells appear as small khaki-colored cells and are less pliable than the normal RBCs. And typically in this kind of eyes, again, there is communication between the anterior and the posterior chamber, letting the ghost cells to migrate into the anterior chamber, and then the trabecular meshwork causing an obstruction. Both of the situations of a hemolytic glaucoma and ghost cell glaucoma, like I mentioned, follow vitreous hemorrhage. The hemolytic glaucoma occurs soon after the hemorrhage happens, whereas ghost cell glaucoma happens 1 to 3 months later. The treatment in both these situations is to have a vitrectomy to clear up that vitreous hemorrhage. Retinal detachment can sometimes present with elevated intraocular pressure. If you remember, Typically, retinal detachment means low pressure, and the reason for that is increased outflow via the RPE absorption techniques. It could also be because of decreased blood circulation to the ciliary processes, leading to decreased aqueous production. But in any case, typically when you have a detached retina, the pressure is low. But there are certain exceptions to the rule. Schwartz syndrome is one of them, wherein the patient has an anterior chronic retinal detachment with a tear in the ciliary body, exposing the aqueous to the opposite chamber to the photoreceptor area. And so what happens is that the aqueous will wash against this undersurface of the photoreceptor area through that tear in the ciliary body and cause these dead photoreceptors to float into the anterior chamber. And these photoreceptors will cause blockage of the trabecular meshwork, giving rise to elevated intraocular pressure. When you look at these patients, typically they have no flare, but these slightly larger than normal cells floating in the anterior chamber, and these can be recognized as dead photoreceptors under electron microscopic view. And on careful anterior segment, careful examination of the peripheral part of the iris and the ciliary body, one should be able to recognize the chronic retinal detachment, which is the actual source for these photoreceptors. Scleral buckle, if it is too tight, can cause obstruction to the episcleral venous outflow pathway, anterior ciliary body rotation, and angle closure glaucoma. Sometimes, if the patient has a total retinal detachment, can give rise to neovascular glaucoma or uveitic glaucoma. Both of these situations can cause the intraocular pressure to be elevated rather than decreased. Penetrating keratoplasty, the most common cause for patients to lose their vision following penetrating keratoplasty is undiagnosed or misdiagnosed glaucoma. The glaucoma is usually a result of mechanical problems. The angle kind of collapses from a combination of trabecular meshwork area distortion from a small donor, tight sutures, inflammation, peripheral ciliary adhesions, steroid use, etc. So any one of these combinations, if you have a small donor tissue that you're trying to suture to the host rim, or tight sutures, or underlying inflammation, which can lead to PAS formation, and prolonged use of steroids, which is necessary to keep the graft going, any of these situations can give rise to trabecular meshwork compromise, decreased outflow pathway, or compromised outflow pathway in glaucoma. And unless the physician, the clinician is aware of this and on a regular basis measures the intraocular pressure, you can very well miss the glaucoma till it's too late, i.e. till the patient presents to you with loss of vision. Drug-induced, one other word about penetrating keratoplasty in glaucoma. Treatment is the usual. We can start with glaucoma aqueous suppressant medications. If the angle is open, you can try SLT in these patients. Again, if the angle is open, they can do canal procedures to control the intraocular pressure. Should the angle be compromised, meaning if the patient has peripheral ciliary adhesions, then some kind of surgical intervention is needed in this group of patients. And the treatment options include a trabeculectomy, or a glaucoma drainage device surgery, or a cyclodestructive procedure. If the angle is open, it's easy. We can do some kind of canal procedures even though the literature to suggest the long-term benefit of this is missing. In my own practice, I do see some excellent surgical results. When the angle is compromised, then glaucoma drainage device operation is probably my surgical procedure of choice. Even though glaucoma drainage device implantation is associated with a higher risk of graft rejection, it has the better long-term profile in terms of glaucoma control compared to trabeculectomy or cyclodestructive procedures. So I try and do the glaucoma drainage device procedures in these cases with uncontrolled or poorly controlled glaucoma in following corneal transplants. Drug-induced glaucoma. This is an interesting topic in itself. Corticosteroids. We use steroids for almost everything in ophthalmology. You do cataract surgery, you want to use steroids to suppress inflammation. You have uveitis, you do that. You have trauma, you use this. Allergies, you use steroids. So steroids are being used more and more in treating a variety of conditions in the eye. And you have to be aware that a third of the population, or what we call steroid responders, in regards to their response to elevated intraocular pressure when they are put on steroids. A significant number of primary open-angle glaucoma patients are what we call steroid responders. The increase in the intraocular pressure results from outflow resistance. And people believe, or so there are some papers to suggest that the GAG material or the glycosaminoglycan basement material in the juxtacanalicular area is increased following the use of steroids, giving rise to outflow resistance, consequently increasing the intraocular pressure. Steroids given in any route, you got to understand this, whether it's a nasal, topical, injection form, oral, it really doesn't matter. Even if you apply steroids to skin, it can cause the pressure to go up. And the steroid-induced glaucoma can mimic primary open-angle glaucoma. Also remember, when the intrinsic steroid levels are increased, such as in Cushing syndrome patients, they can have elevated intraocular pressure. Periocular steroid injections can also cause the pressure to go up. These patients can present with optic nerve damage many years later with normal intraocular pressure, meaning, for example, if you have a patient with Cushing syndrome that has undergone surgical excision of the tumor and the Cushing syndrome is resolved, while the patient is on Cushing syndrome, the patient may have elevated intraocular pressure and could potentially have sustained damage to the optic nerve. Now that the treatment has been offered to the patient and the Cushing syndrome is resolved, many years later, follow-up examination, patient may have a vision field defect and optic nerve damage consistent with glaucoma, except in this situation, the pressures are okay and it's non-progressive. So it's important for you to take the history to distinguish these kind of situations from active disease processes that will need treatment. Intravitreal steroid injections are being used more commonly in the recent past, especially in regards to diabetic retinopathy, uveitis, and macular degeneration. They are associated with transient elevation of intraocular pressure in almost 50% of the patients. 25% of these need topical glaucoma medications. 1 to 2% may need surgery. Now, there are some long-acting steroid implants that people are inserting into the vitreous cavity, especially in patients with chronic unrelenting uveitis. Now, these patients are frequently associated with elevated intraocular pressures and sustained glaucoma that they may need surgical intervention to control the intraocular pressure. So almost 50% of the patients with the intravitreal steroid implants will need some kind of glaucoma surgery to control the resulting pressure. Remember, filtration surgery has a very high success rate in this group of patients following intravitreal steroid injections. Lastly, cycloplegic drugs that we use normally in our clinic can occasionally increase intraocular pressure in patients with open angles. This is more likely to occur in patients with primary open angle glaucoma, pseudoexpellitic glaucoma, or pigment dispersion syndrome, and those who are on miotics. The exact mechanism as to how the cycloplegic agents increase intraocular pressure is unknown, even though there is a suggestion that it's to do with the change in the trabecular meshwork configuration following cycloplegia. That concludes our lecture for today. In fact, that concludes the lectures on open angle glaucoma. Here are some references that I would recommend for you to read and understand these topics that we discussed today. So I want to thank you for your patience, and please look out for more lectures on MediTred on our YouTube website. Look out for our upcoming CME board review courses. And any comments that you have, please send them to il@meditred.com. Thank you.